normal volumes of the CSF in infant or in adults. So we will discuss different values of the CSF in different infections. Then we will discuss or talk about the functions of the CSF. Then there are the certain types of the hydrocephalus. Then what happened to the patient or a patient of hydrocephalus, how present with to us, and what are the signs and symptoms by which a patient presented to us. So in last we will discuss about the diagnosis of the hydrocephalus and what are the treatment options of the hydrocephalus. So first of all about the definition. So hydrocephalus is a Greek word which means water in the head, or we can also say that hydro mean water and cephalus mean head. As the name implies, it is a condition in which primary characteristic is excessive accumulation of fluid in the brain. Although hydrocephalus was once known as water on the brain, the water is actually cerebrospinal fluid, but not the actual water, but is the CSF which is excessively accumulated in the ventricle systems of the brain. Excessive accumulation of CSF result in the abnormal widening of the spaces in the brains called ventricles, and this widening creates potentially harmful pressure on the tissues of the brain, which then leads to signs and symptoms of the hydrocephalus. So it is maybe the secondary to increase production or decrease absorption of the CSF. We will discuss in we will discuss in our upcoming slides. So first of all, in this picture, you can see that these are the meninges which surround the brain and the spinal cords. So these meninges are the continuous. First of all, there are the three layers which surrounds the brain tissue. These are the dura mater, arachnoid matter, and the pia mater. So these three layers continues downward, and they also enclose the spinal cord, and they end up at the level of S2 vertebra. Okay, so this is a normal picture of the ventricles of the brain. As we know that there is the spaces inside the brains which are called ventricles. So there are four ventricles in the brain. Two are the lateral ventricles. Here in this picture you are seeing the sagittal view of the ventricles. So there are the two ventricles which are called lateral ventricles. Then comes the third ventricles and then the fourth ventricles. So this ventricular system is made up of four ventricles which are connected by the narrow passage. So normally CSF flows through the ventricles, exist into cisterns, and these cisterns are the closed spaces that serve as reservoirs, and these cisterns are usually present at the base of the brain. And then this baths the surface of the brain and spinal cord and then reabsorb into the bloodstream. So in another picture, yes, here you can see, so these are the two lateral ventricles. So lateral ventricles have certain horns, which are, these are the frontal horns, then temporal horns, and then the occipital horns. So this is the left ventricle and this is the right ventricle. So both left and right ventricles open into third ventricle through a foramen which is called foramen of Monro. So then this third ventricle drain into fourth ventricle through another duct. This is called cerebral aqueduct, or this is also called aqueduct of Sylvius. Okay. So from this aqueduct of Sylvius, CSF drain from third ventricle into fourth ventricle, and from fourth ventricle, so CSF either drain into lateral axis or drain into the central canal of the spinal cord. So if it is going to drain into lateral axis, it is through the foramen of Mejendi, and if it is going to into the central canal of the brain, spinal cord, then through the foramen of Lashka. So this is the anatomy of the ventricular system. Here in this picture you can also see that, so these are the ventricles of the brain, there are the certain spaces or certain places in the ventricles where a special substance is present in the ventricles which is called choroid plexus. So these choroid plexus is the site where normally CSF produce. So from the choroid plexus, CSF went to the different foramens into the where we have already discussed lateral ventricle, third ventricle, then cerebral aqueduct to fourth ventricle. From there, then CSF with the help of these systems goes into the arachnoid villi. So these arachnoid villi are the or arachnoid granulations is the site of CSF absorption. Means CSF absorbed through these arachnoid granulations. So again in this picture you can see that we have shown the pathway or the site of the formation. So the CSF is produced in the choroid plexus of the lateral ventricle, and from the lateral ventricle through the interventricular foramen, which is also called the foramen of Monro, the CSF goes into third ventricle, and from the third ventricle through the cerebral aqueduct into the fourth ventricle, and from the fourth ventricle it goes laterally to the from the foramen of Lashka and again into the central canal of the spinal cord to the foramen of Magendie, and from here it goes into subarachnoid space and and from there it goes into the arachnoid villi, and from arachnoid villi, which is present in the dural sinuses, CSF is absorbed. Here in this picture again you can see this is shows the route of the CSF flow. First of all, it is produced in the lateral ventricles. From the lateral ventricle with the help of foramen of Monro, it goes into the third ventricle, and from the third ventricle with the help of cerebral aqueduct it goes into fourth ventricle, and from the fourth ventricle it is through the foramen of Magendie goes into cisterna magna or superior cistern, then into the cerebral hemisphere, and in last into the arachnoid villi, which is present in the superior sagittal sinus, which is the dural venous sinus, and then the right transverse sinus, sigmoid sinus, and the internal jugular vein. So this is the pathway of the flow of the CSF. Okay, if we discuss about the volume of the CSF, so in a normal adult person, usually 44 or 450 ml CSF produced every day. Okay, if we are going to count it in the in minutes, so CSF production is 0.3 to 0.37 ml in minute or 20 ml per hour. But if we talk about the total volume, either it is produced 450 ml in day, but in total volume of the CSF in the brain or the spinal cord is about 150 ml. Okay, so in 150 ml, only 25 ml is in the ventricle subbrain. So rate of the production is 20 ml per hour. So ventricle contains only 20% of CSF volume, but the remaining CSF, 80% CSF volume is present in the subarachnoid space around the brain and the spine. Okay, but the in an adult, total volume of CS is about 125 to 150 ml. Again, we have already discussed about the production of the CSF. We discussed that 70% of the CSF is produced by the choroid plexus, which is lined by the ependymal cells. As you know that the ependymal cells are the neuroglial cells. Okay, 18% of the CSF is the ultrafiltration of the plasma, and 12% is the metabolic water produced. So this is the production of the CSF. So as I have told that there are certain places in the ventricles which contain special ependymal cells, and these are the called choroid plexus, and these choroid plexus are primarily located in the roof of the fourth ventricle, then inferior medullary vellum of the lateral recess to the foramen of Lashka, posterior roof of the third ventricle, floor of the bodies, and the roots of the temporal horns of the lateral ventricles. So we have discussed that these choroid plexus is present in the fourth ventricle as well as in the third ventricle as well as in the lateral ventricles, but no choroid plexus is present in the cerebral aqueduct. Okay, so as I told that we can discuss about the values of the CSF in the different sort of infections. First of all, if we see in normally, if the we will talk about the normal CSF. So its appearance is it's a waterless clear fluid. Its normal pressure is 9 to 18 centimeter of water. Okay, and the WBC's count is less than 5, and the amount of glucose is 50 to 75 ml, and total protein is in between 15 to 40 ml. But in different infections, when we go for the CSF detailed report, the parameters of the values are changed. Like in the bacterial infection, mostly the appearance becomes not clear but it's cloudy, and the pressure rises from 19 to 80 to 18 to 30 centimeter of water, and TLC count is increased from 100 to thousands, and mostly in the bacterial infections predominant blood cell is the neutrophils. As we know that the bacteria take energy from the glucose, so in bacterial infections, the glucose amount of the glucose in the CSF will decrease. This is the pathognomic sign, or we can say that this is the diagnostic indicator that the patient is suffering from the bacterial infection. So if a patient you draw a CSF from patient, if the appearance is cloudy and if the TLC count is more than 100 or up to thousands, and the predominant cell is the neutrophils, and the glucose count is less than 45, then the most probably the diagnosis patient is suffering from the bacterial infection. The protein count is also increased, but sometimes it is normal in the bacterial infection. Okay, in the tuberculosis, again, the appearance will be not clear, but the appearance will be cloudy, and the pressure is in between the 18 to 30 centimeter of water, and the TLC count is less than 500, and the predominant cells will be lymphocytes, but not the neutrophils. And again, in the glucose contents will be decreased, and the protein content is up to will be increased or normal. Again, in fungal infection, the appearance will be cloudy. The pressure is in between the 18 to 30 centimeter of water, and the TLC count is less than 300, and the predominant cells are the lymphocytes. Glucose count is also decreased, and the protein contents are raised. And in aseptic conditions, again, the appearance will be clear, the pressure will be within normal limits, even the TLC counts is less than 300, and mostly the predominant cells will be polymorph neutrophils but not the lymphocytes, and the glucose content is in between the 15 to 100, and the protein content is also normal. So these are the certain different values of the CSF through which can help you in the diagnosis. Mostly you have to focus on the bacterial, TB or the viral infections. So again, I will repeat, in the bacterial infection the appearance will be cloudy, the TLC count will be raised, and the predominant cells will be the neutrophils, and the glucose count will be decreased. In TB tuberculosis, again appearance will be cloudy. The cells count is not as much as in the bacterial infection, and the predominant cells will be the lymphocytes, and glucose content will be less than 45, and proteins count will be normal or increased. In viral infection, what happens? The appearance will be mostly colorless. Again, TLC count will be raised, and the predominant cells will be lymphocytes. Glucose count will be normal, but the total protein value will be raised significantly. As we know that the whole body of the virus is made of protein coat. So when virus is going to replicate within the CSF, it will produce large amount of protein. That's why protein counts are raised in the viral infection. So what is the function of the CSF? So CSF has three important life-sustaining functions: to keep the brain tissue beyond or acting as a cushion or shock absorber. Also, it acts as a vehicle for delivering nutrients to the brain and removing waste from the brain, and to flow between the cranium and the spine and compensate for change in the intracranial blood volume. Okay, so the balance between the production and the absorption of CSF is critically important. So these are the functions of the cerebrospinal fluid, but it removes the waste from the brain, it carry the nutrients to the brain, and it also cause the cushions effect to the brain. Okay, so it also regulate various brain functions and neurotransmitters, paracrines, and endocrines. Even hypothalamic hormones are secreted into the CSF, and then they are transported by the ependymal cells to the hypophyseal portal system. Okay, so this is the again a picture which is showing the ventricles of the brain. So this is the lateral ventricle, this is the frontal horn of the lateral ventricle, this is the temporal horn of the lateral ventricle, and this is the occipital horn. And here you can see this is the third ventricle, and third ventricle through the cerebral aqueducts is drained into the fourth ventricle. So if we are going to discuss about the types of the hydrocephalus, so hydrocephalus may be congenital or acquired. Hydrocephalus may be communicating or non-communicating. Hydrocephalus, communicating hydrocephalus is also called non-obstructive hydrocephalus, and non-communicating hydrocephalus is called obstructive hydrocephalus. So why? First of all, I will tell about the congenital or the acquired. Congenital hydrocephalus is present at the birth and may be caused by either events or influences that occur during the fetal development or genetic abnormalities. Acquired hydrocephalus develop at the time of the birth or at some point afterward. This type of hydrocephalus can affect individuals of all ages and may be caused by injury or disease. So, as it is, the hydrocephalus may be communicating or non-communicating. So, communicating hydrocephalus occur when the flow of the CSF is blocked after it exits the ventricle. This form is called communicating because the CSF can still flow between the ventricles which remain open. So, there is a communication between the all ventricles, lateral ventricles, third ventricle, and the fourth ventricles. But in non-communicating hydrocephalus, which is also called obstructive hydrocephalus, It occurs when the flow of the CSF is blocked along one or more of the narrow passage connecting the ventricles. And for example, one of the most common cause of the hydrocephalus of the non-communicating hydrocephalus is the aqueductal stenosis. So in aqueductal stenosis, the CSF cannot flow from the third ventricle to the fourth ventricle. So this type of hydrocephalus is called non-communicating or obstructive hydrocephalus. So one of the other cause of the hydrocephalus is they either may be due to the excessive production of the CSF or either may be due to the decreased reabsorption of the CSF. So these both things called hydrocephalus. Okay, so here in this slide, you can see that the causes of the communicating hydrocephalus, it may be congenital, like in achondroplasia, or it is associated with the craniofacial syndrome. What happened in craniofacial syndrome? Then there is the abnormal or asymmetrical development between the facial and the cranial bones. So, what are the acquired causes? Acquired causes are those causes which are developed later on. So, these are post-hemorrhagic, intraventricular, or subarachnoid choroid plexus papilloma or choroid plexus carcinoma. In both these cases, there is an increased production of the CSF by the choroid plexus, either in the venous obstruction as in superior vena cava syndrome or post-infectious. So, these all are the acquired causes of the communicating hydrocephalus. So if we are talking about the non-communicating hydrocephalus, it means there is no communication between all the ventricles of the brain. So it again it may be congenital by birth or it may be developed later on. So in congenital, it is caused by the aqueductal stenosis, as we have discussed already. Congenital lesions like vein of Galen malformation. A vein of Galen is which is called also internal, which is also called internal cerebral vein. It is a great significance at it runs near to the ventricles. If there is a malformation of the vein of Galen, it causes the obstruction of the ventricles. So some congenital tumors, I will show you the pictures in the later on. Then there is a arachnoid cyst. This cyst is formed in the anterior third ventricle and cause the blockage of it is formed in the root of the third ventricles from where the foramen of bone of the lateral ventricles entering the third ventricles. So due to this cyst, these foramen of bone are blocked, which can cause the hydrocephalus. So Chiari malformation either with or without meningiomyocele. What happened in the Chiari malformation? There is a downward herniation of the cerebellum which cause the pressure on the central canal and which leads to the hydrocephalus. So the other causes are X-linked hydrocephalus like Dandy-Walker malformation. I will show you the pictures in the upcoming slides. So the acquired causes of the non-communicating hydrocephalus are the aqueductal gliosis, like post-hemorrhagic or post-infectious, space-occupying lesions which develops later on, such as tumors or the cyst or head injuries. So here in this picture, you can see these are the certain tumors. You can see this. This is the foramen of monogliosis, which can leads to the obstruction of the foramen, and so there is a no flow of CSF from the lateral ventricle into the third ventricle. So again, in this picture, you can see the third ventricle chiasmatic gliosis or craniopharyngiomas. Or here in this picture, you can see there's a pineal lesion tumors. So this tumor can also block the third ventricle, and there is a no flow from the third ventricle to the cerebral aqueduct, or either it is the obstruction at the level of the fourth ventricle. Fourth ventricle tumors like medulloblastoma, ependymoma, astrodymoma. So these all are the causes of the obstructive or the non-communicating hydrocephalus. Okay, so what are the signs and symptoms of the? First of all, I will tell what caused the hydrocephalus. The cause of hydrocephalus is still not well understood, but as we already discussed that it may be from the inherited genetic abnormalities like genetic defects that cause aqueductal stenosis or developmental disorders, as we have already discussed, like achondroplasia. So always always think about the two things in mind. First, in hydrocephalus, either there is the increased production of the CSF or either there is a decreased absorption of the CSF from the arachnoid villi. So what are the signs or the symptoms of the hydrocephalus? The symptom of hydrocephalus vary with age, disease progression, and individual differences in tolerance to the condition. For example, an infant's ability to compensate for the increased CSF pressure and enlargement of the ventricle differs from adults. Why? Because infant skull can expand to accommodate the buildup of CSF. Because of sutures in infant, the sutures are not closed. The fibrous joints that connect the bones to the skull have not yet closed. So that's why in the infant they can sustain large amount of the CSF as compared to adults. Or you can say that in the infant symptoms does not develop very quickly, but the adults, if there is a slight enlargement of the ventricles, it cause the pressure on the brain can come, and adult will develop the sign or symptom of the hydrocephalus. So what will the symptoms in the infants? It will be a rapid head growth, tense frontal eye, distended scalp veins, decreased feeding or poor head control, then again the splayed cranial sutures, sun setting eyes, Perinaud sign, and frontal bossing. So what is the Perinaud sign? Perinaud sign is the combination of three things in which there is a upward gaze palsy, there is a convergent stigmas, and the third thing is the bilateral lid detection. So these all are the signs and the symptoms of hydrocephalus in the infant, but in adults, what happens due to the increased size of the ventricles, it can cause or compress the normal brain parenchyma. So adults will develop altered level of consciousness, lethargy, vomiting due to the increased intracranial pressures, seizures, and sunsetting eyes. Okay, there is another type of the hydrocephalus which we have not discussed yet. Uh, this type of the hydrocephalus is called there are two type of other form of the hydrocephalus which do not fit exactly into the categories which we have mentioned above, and these are primarily affect the adults. One is called hydrocephalus ex vacu, and the other is called normal pressure hydrocephalus. So the hydrocephalus ex vacu, which occurs when stroke or traumatic injury can damage to the brain. So in this type of cases, the brain tissue may actually shrinks. So normal pressure hydrocephalus, the other type of the hydrocephalus is the normal pressure hydrocephalus. In normal pressure hydrocephalus, there are tried of three things, which are the dementia, gait ataxia, and urinary incontinence. So if a patient which comes to you, if he has the age of 50 years or the 60 years and the family is complaining that he is having the forgetfulness and he is unable to walk and he has a drunken gaze and he had poor control in his urination, then you have to think about the normal pressure hydrocephalus. So here in this picture, you can see that there is an enlarged head circumference. You can see the prominent veins. You can see the frontal bossing. You can see the sun setting eyes. So these all are the signs and symptoms of the hydrocephalus in the infants. Okay, so how you are going to diagnose the hydrocephalus? So the diagnosis is the either radiological or either you can take this mostly we used to diagnose the hydrocele with the help of the radiology. We can diagnose with the help of x-ray, ultrasound, ct brain, or the mri brain. Okay, so if we are going to say about the uh, diagnosis, this is the x-ray of a young child, which in this x-ray you can see there's a separation of the sutures, erosion of the posterior crinoids, so increase conventional markings, like you can see that these are the gyral impressions which are seeing, or you can appreciate on the skull bones. So the gyral impressions on the inner table of the skull, then silver beaten appearance. So these all are the findings you can see on the uh, X-ray of the patient of the hydrocephalus. But X-ray is not the modality of the choice for the diagnosis of the hydrocephalus. The main modality of the choice for the diagnosis of the hydrocephalus is either CT scan or the MRI. Okay, so we can diagnose the hydrocephalus through clinical neurological evaluation or by using cranial imaging techniques like ultrasonography, CT scan, MRI, or pressure monitoring techniques. Okay, so you can see the X-ray. So this is the ultrasound of the patient. Here in this ultrasound, this is the normal ultrasound of the patient. You can see the ventricle, which is not as much dilated, but it contains a little amount of the CSF. So in the next picture, you can see there is a massive accumulation of the CSF in the ventricles, and the ventricles are the dilated. So in ultrasound, through ultrasound, you can also diagnose the hydrocephalus. So the modality of the choice, as I have already told, that either it is the CT scan or the MRI. So here you can see the CT scan of a patient which is showing, but this is the normal CT scan which is showing the lateral ventricle. These are the frontals of the lateral ventricle, and these are the occipital horns, and this is the fourth ventricle. But you cannot appreciate the temporal horns of the lateral ventricles in the normal CT brain. But in this picture, you can see the dilated frontal horns of the lateral ventricles and the occipital horns of the lateral ventricles. Here in this picture, you can appreciate the sulci or gyri, but here in this picture, which is showing the hydrocephalus, because of the pressure of the CSF to the brain parenchyma, you cannot appreciate sulci and gyri. So again, this is the MRI of the patient. Okay, this is in this MRI you can see there is a stenosis of the cerebral aqueduct. So it means this is the communicating or non-communicating hydrocephalus. So this is non-communicating hydrocephalus because the no communication between the lateral ventricle, third ventricle to the fourth ventricle. As we have already discussed that this is the aqueduct, cerebral aqueduct which connect the third ventricle to the fourth ventricle. So this is the type of non-communicating hydrocephalus or obstructive hydrocephalus. Okay, now as we have discussed the causes of the hydrocephalus in the previous slides, now I will show you the different images which can confirm or which will tell the things which we have already discussed. So first of all, this is the MRI of a patient. This is the normal MRI, which is showing the small amount of the CSF in the lateral ventricle. But here you can see that the dilated frontal and the occipital horns of the lateral ventricle. But why we are calling it the normal pressure hydrocephalus? Because the CSF pressure is within normal limits. So we have discussed that this type of the hydrocephalus occurs in the adults, and there is a classical triad for the diagnosis of this hydrocephalus, normal pressure hydrocephalus. That patient usually present with the dementia, with the gait anomalies, and the third thing is urinary incontinence. Okay, so here in this picture you can see that the craniopharyngioma, which is the tumor of the Rakit pouch of the pituitary, so in this also causing the obstructive hydrocephalus and causing the obstruction in the flow of the CSF. Again in this picture, this is the intraventricular tumor. This tumor is causing the obstruction within the ventricles, and again this is the example of the non-communicating hydrocephalus. Here in this picture, you can appreciate a small cyst which is called the colloid cyst, which is present in the anterior ward of the third ventricle. And again, this here you can see a large colloid cyst which is present in the third ventricle. And this cyst is blocking the both foramen of the Monro's and the nose flow of the CSF from the lateral ventricles to the third ventricle. And again, this is the example of non-communicating or the obstructive hydrocephalus. So again, you can see that this is the pineal gland tumor. Again, this pineal gland tumor is causing the obstruction at the level of the third ventricle. So there is no connection between the upper ventricles to the lower fourth ventricles. And again, this is the example of obstructive or non-communicating hydrocephalus. Okay, so this is the medulloblastoma, which is a tumor of the mostly posterior fossa, and we know that in the posterior fossa, fourth ventricle is present. Again, this tumor is causing obstruction to the fourth ventricle, and again, this is the example of obstructive hydrocephalus. So here again, this you can see this is the cerebellar tumor. Again, this is causing or abutting or compressing the fourth ventricle, and this is the example of obstructive hydrocephalus. So enlarged, this is the CP angle tumor. Again, these CP angle tumors when get enlarged, it can cause pressure on the fourth ventricle and cause obstructive hydrocephalus. So this is a picture of TB meningitis. As we know that in the TB meningitis, the CSF get infected, turbid, and this infected CSF block the ventricular foramens and cause hydrocephalus. So this is the intraventricular bleed. So this intraventricular bleed also can this intraventricular bleed also can disturb the flow of the CSF or can distract the normal flow of the CSF from the different foramens into the different ventricles and then due to the electrolyte granulation. So this is again the example of the obstructive hydrocephalus. So we have also discussed the cause of the hydrocephalus, the Arnold-Chiari malformation. As I have told you that in the Arnold-Chiari malformation, there is a downward displacement of the cerebellar vermis or the cerebellar tonsils. So these tonsils, this downward displacement of cerebellar tonsils cause the obstruction of the central canal. So again, this cause hydrocephalus. So this is a dandy Walker wall malformation. As if you remember, we discussed all these things in the previous slides in the causes of the hydrocephalus. Here I am just showing you the different images. So what happened in the dandy Walker? There is the agenesis of the cerebellum. So when there is the agenesis of cerebellum, here is a cistern which is called cisterna magna. So there is a large cisterna magna. So what is the classical triad in the dandy walker is there is cyst in the posterior fossa, there is the agenesis of the cerebellar vermis and the hydrocephalus. Okay, so now we will discuss about the treatment of the hydrocephalus. So okay, before discussing about the treatment of the hydrocephalus, we have also, if we are going to manage the hydrocephalus we are going to underwent for a surgery, first of all, we have to take the detailed report of the CSF, which is called CSF, DR and CSF, and in which we have to see that either patient have any sort of infection in the CSF or CSF is clear. Make sure if the patient is having suffering from the infective CSF or either which is bacterial or viral, then we have to avoid for the surgical options for the treatment of the hydrocephalus. So there are two type of treatment for the hydrocephalus. One is the medical treatment and the other is the surgical treatment. In medical treatment or in the medical therapy, so we definitely hydrocephalus. We do not mean this is not the effective way to treat the hydrocephalus. In which we give the diuretics like acetazolamide, like furosemide to decrease the production of the CSF or to increase the absorption of the CSF and in medical therapy by giving the diuretics we just decrease the amount of CSF, but this is not the definitive therapy. So the definite therapy for the management of the hydrocephalus is the shunt. So hydrocephalus is most often treated by surgically inserting a shunt system. This system diverts the flow of CSF from the CNS to the other area of the body and where it can be absorbed as part of the normal circulatory process. So, but before we are inserting a shunt, there are the temporary mears, which is the serial lumbar or the ventricular punctures in the very small children, or EVD in case of infectious or hemorrhagic etiology. So again, as I told, if the patient has infectious CSF, then we will not go for the shunt, but we will do the EVD. EVD stands for extraventricular drain. So what is the definitive treatment? So that is definite treatment is the minimal invasive, which is the third ventriculostomy, which is the endoscopic technique, or either we go through the shunts. Okay, so the shunt system divert the flow of CSF from the CNS to other area of the body. A shunt is a flexible but sturdy plastic tube. A shunt system is consists of the shunt, a catheter, and a valve. Okay, so one end of the catheter is placed within the ventricle inside the brain or in the CSF outside the spinal cord. So this is the ventricular end of the shunt. You can see this is the ventricular catheter and this is the wall. So this ventricular catheter will be inserted in the ventricle of the brain. Then it is connected with the wall, and this wall is again then connected with the distal catheter, which is goes subcutaneously from the skull to the mostly peritoneum. Okay, so mostly there are the other some other side where we can place the other end of the catheter, but commonly this is placed within the abdominal cavity, but it can also be placed in the side of the body such as chambers of the heart or areas around the lungs where CSF can drain and can be absorbed. So a wall is also located along the catheter, maintains one-way flow and regulate the rate of the CSF flow. So this is the ventricular systole. Here you can say that So this approach is called frontal approach. If we are inserting the ventricle end into the frontal horn of the lateral ventricle, the other is the occipital approach. In this approach, we are inserting the shunt into the occipital horn of the lateral ventricle. You can also see here the different parts of the shunt system. So this is the ventricular catheter, this is the wall, and then this is tube which is present under the skin, and this is inserted into the peritoneal inside the peritoneum. This is also called peritoneal end of the shunt. So in this table you can see the common shunt types like ventriculoperitoneal shunt, in which ventricles there is a kind of communication between the ventricle to the peritoneal cavity. Then the other is the ventriculoatrial shunt, in which there is a connection of the ventricle to the right atrium of the heart. Then ventriculopleural shunt, in which ventricles are connected to the pleural cavity. And last, lumboperitoneal shunt, in which the lumbar spine, the ventricle end is connected, inserted into the lumbar spine, and then this is connected to the peritoneal cavity. So these are the different types of the shunt. But in our practice, mostly and commonly we use the ventriculoperitoneal shunt. So this is a picture of the lumboperitoneal shunt, in which the one end is inserted into the arachnoid space of the lumbar vertebra, and the other is inserted into the peritoneal cavity. So another technique is the minimal invasive technique, which is also called the third ventriculostomy. So in this technique, we access into the third ventricles with the help of the endoscope. And what we do, sorry, not the third ventricle but the lateral ventricles. So what we do in this technique, there is a septum which is present between the two lateral ventricles, which is called septum pellucidum. So we just do the fenestration of the septum pellucidum. And other what thing we do, uh, we just make a hole in the roof of the third ventricles, and we connect this we make a connection from the roof of the third ventricle to the cisterns which is present around the midbrain. So this technique is called third ventriculostomy. So these are the different options, and thank you so much for your concerns.